Hello, I'm Dr. Sally Brooks, Chief Medical Officer of Kindred Rehabilitation Services. This session is designed for physicians, clinical liaisons, admission teams, and leadership teams at all of our facilities and sites. The goal is to challenge managed care Medicare Advantage plans when their rationale for denying care is inappropriate. Let's keep the Medicare beneficiaries at the center of care. Now, let's begin. The managed care view of skilled nursing facilities is the following. Health plans use Milliman version 17 or interqual criteria as guidelines. The intent of criteria is really to use them as guidelines, which requires medical expertise to interpret. The goal of the health plan is to pay for care in the lowest cost setting. In this example, home health care. Care plan medical directors of health plans need education on types of care that can be pragmatically delivered in the skilled versus home setting. Many health plan medical directors have never practiced in post-acute care delivery sites and are unfamiliar with capabilities. Describing the skilled nursing patient. 40% of the 35% of Medicare beneficiaries needing post-acute care meet the medical necessity criteria for skilled care as the discharge site following the hospital stay. Clinical descriptors of skilled nursing patients is important to share with health plans so that they best understand the appropriate patient for the skilled setting. Typically, these patients require 24-hour nursing supervision for acute and chronic medical condition management. They require activities of daily living and/or MOD max mobility assistance. They require and can participate in up to 2 to 3 hours of therapy daily. And there are medically necessary physician visits to oversee this care. Visits typically more frequent at the beginning of the stay. Here are some common admission diagnoses. Complex medical conditions such as a CHF or COPD exacerbation, prolonged hospital length of stay with debility, wound care, stage 2 or greater wound, general surgery with post-op complications or orthopedic surgery, such as a single joint replacement, or an infection requiring IV antibiotics. It's important that when talking to a utilization management nurse or medical director from a health plan to provide detailed information in the documentation, but also be able to verbally paint the picture. For example, can you describe why there's a safety or medical risk if the patient's not admitted to the skilled facility? And this can be either from a medical or therapy need perspective. Will the patient fail in a lower acuity environment because the same care oversight cannot be provided? What are the consequences of not receiving that skilled care? For example, might there be an unplanned ER visit or rehospitalization, an injurious fall, or a worsening of that new wound? What if the patient does not receive frequent physician oversight? It's important that we participate in educating patients, caregivers, and clinicians. Although the hospital discharge planners are supposed to be providing this information to the patients, they do not always do so. So we can be part of that education team. Note that Medicare beneficiaries, and this includes either Medicare fee-for-service, Medicare Advantage, and patients with supplement plans, all have the notice of non-coverage appeal rights. Again, we have the opportunity to educate hospital case managers, discharge planners, patients, their representatives, and perhaps their referring or attending physicians, and the health plan medical directors of those rights. The patient, their representative, and/or physician need not obtain an appointment as representative designation to file for an organization reconsideration at this level of appeal. Our clinical liaisons can certainly provide information, including the phone number of the health plan, to initiate an appeal, but they cannot file an appeal on behalf of the patient, nor can they obtain an appointment as representative designation. Although a standard reconsideration is 14 days, because the patient is in the acute care hospital or needs to access this care quickly, our advice is for the patient to file a fast appeal, which means the health plan must make a designation decision within 72 hours. We recommend this because there is a potential adverse consequence of a prolonged waiting time for a decision, such as a decline in patient function. There are 5 levels of appeal for Medicare Advantage beneficiaries. First, before the reconsideration, we should ask the referring or attending physician of the patient in the current setting to ask for a peer-to-peer discussion with the health plan medical director. It's often helpful if our skilled facility medical director can be part of that call, however, not always feasible. The reason for this is our medical director understands the capabilities of our facility the best. If that peer-to-peer review fails and the health plan upholds their denial, this is when the patient, their family, appointed representative, or physician can file an appeal. That kind of appeal is called a reconsideration. That's the first level of appeal. And what this means is that case is reviewed by a different medical director than one that is performed during the peer-to-peer discussion. Level 2, review by the Part C independent review entity. Note that CMS contracts with Maximus to do this. Number 3, a hearing with an administrative law judge. Number 4, a review by a Medicare Appeals Council. And number 5, judicial review by federal district court. Note, in my experience, if there's thorough documentation, many appeals are overturned after step 1 or 2. To learn more about Medicare appeals, the website is the bottom of the slide. Appeals for Medicare Advantage beneficiaries are important because of the following. Medicare Advantage plans must report their percent of appeals that are overturned. In other words, it's not viewed favorably if a health plan has a high percentage of overturned decisions by that Medicare Part C independent review entity called Maximus. This appeal overturn rate factors into the health plan's 5-star rating. Much like a skilled facility has a 5-star rating, so does a health plan. Their overall star rating score for quality of those services covers 36 different topics in 5 categories. Please note that 3 of the 5 categories are based around member experience, as outlined here on the slide. In other words, CMS provides a mechanism to assure that Medicare Advantage members get their covered benefits. Medicare Advantage admission approval submission process is outlined on the following pages. This is tactical guidance around how to help the patient through the appeal process. Keep in mind our goal. It's to improve communication between our services as the skilled nursing care provider and the payer. We want to assure that the CMS beneficiary, known as our patient, and the health plan's payer enrollee receives their Medicare benefits while meeting CMS compliance guidelines. Step 1 of the process is submission of the request for the service. Typically, the insurance case manager or utilization review nurse is notified of the request for skilled nursing rehab services. They will review the documentation that supports the skilled nursing rehabilitation services. Step 2, then the Medicare Advantage plan reviews this against documentation guidelines. So they will look at the clinical information that is submitted and compare these to the Interqual or Milliman or sometimes other guidelines, such as NaviHealth has their own guidelines. Again, important to point out, because these are guidelines and not a black and white checklist, this is where step 5, the acute care physician attending, getting involved in a peer-to-peer discussion with the insurance medical director can be very helpful. We can also ask that that peer-to-peer physician be in a like specialty. In other words, for a skilled nursing facility patient, a medical director from the health plan who has a background as a pediatrician would not be appropriate. It's important that we document all the steps of this Medicare Advantage plan decision submission. The CL may choose to also submit the guideline data that they have. Perhaps they have an Interqual copied form about skilled facility guidelines and submit that with the documentation. Whenever we submit the documentation, we want to note the date and time of that authorization request. Sometimes this is the time of the fax. It's important because the clock starts ticking on an appeal process, and it's important to know how much time prior to the appeal was requested has occurred. The insurance case manager then approves the request or sends it to the insurance physician for determination if their review does not meet the interpretation of the criteria. Note, a nurse case manager of the health plan cannot deny a service without having a physician review the content also. Only a physician can deny services. At this point, the insurance physician makes an organization determination. They either approve or they deny. This organization determination is communicated via fax or delivered via letter to the hospital discharge planning personnel where the enrollee is being cared for. And sometimes our clinical liaisons are notified at the same time. Specify that this documented decision should be delivered in person or fax to the acute care hospital where the patient is. Mailing a decision to the patient's home is unacceptable. Step 3, patient reconsideration or appeal. The enrollee, their appointed representative, or physician may then appeal the adverse organization determination, also known as a denial, of services by requesting a reconsideration. Again, please note our clinical liaison or Kindred hospital representative employee may not become an appointed representative, but we can provide the contact information. These persons should always request an expedited reconsideration, also called a fast appeal. It's advantageous if the patient's physician also requests an expedited reconsideration at the same time. We have found that when the physician also requests reconsideration, that the appeal process goes much more smoothly and the decisions are in our favor. Note, if the physician requests an expedited appeal, it must be honored. Once the plan receives an expedited request, it's always good just to check back in with the insurer and assure that the time frame for decision will be less than 72 hours. Many times health plans make this decision within 24 hours. Note that some Medicare Advantage health plans might communicate with the enrollee at this point to ask for a reconsider request extension. We should advise the member or our patient not to give them an extension. Sometimes this is done for the plan's convenience if the reconsideration request comes in on a Friday, for example. However, if they do ask for a reconsideration request, they should be providing that in writing for the enrollee to sign, making sure that the enrollee understands the implications of the extension of a reconsideration request. At this point, the insurer reconsideration request is either sent to a third-party external review organization, or reconsideration is performed internally by an internal second physician reviewer at the health plan. It's more common that it's handled internally than sent to a third party at this point in the appeal process. Either the Medicare Advantage plan's second physician reviewer or that external review organization overturns and approves the care or upholds the denial. The reconsideration decision must be communicated to the beneficiary with a decision letter sent by the health plan. It's important, again, at this step that documented decision is sent to the hospital, and some health plans will even deliver that message to the enrollee at the hospital in person. If the reconsideration decision is unfavorable to the enrollee, note that the health plan must submit the case file and its decision for automatic review by that Part C independent review entity called Maximus. The time frame for decision by Maximus is typically within 24 hours. At this step, the patient or appointed representative may contact Maximus to make sure the case was sent and received. At this point, we await Maximus' decision, and then their decision is communicated to the patient via that hospital representative or appointed representative. Here are some tips for process success. As stated previously, note all the event times. When was the request initially submitted? When was additional clinical information submitted for reconsideration? When was the appeal started, etc.? In some of our markets, our staff will email the Medicare Advantage Plan regional supervisor, which is typically a director of utilization management or case management, to assure that they know about the expedited appeal. It's a good time during this contact to ask for process clarification as the case proceeds and to ask the supervisor, what are the time clarifications as the case proceeds? In other words, when might we expect to hear back with the decision? I find it's very useful to include the hospital administration in these communications. In other words, the hospital is looking for a discharge placement on their patient as well. And so including them in these communications can be very helpful. It shows the health plan that we as the post-acute care provider and the acute care provider are advocating on behalf of this patient. To be proactive and to expand the relationship beyond a case-to-case basis, you can ask for a joint quality operation meeting, and this would include the hospital team as well as the Medicare Advantage plan and the post-acute care team. The Division Chief Medical Officer of Skilled Nursing can assist as needed via requests through the Medical Director, Executive Director, and/or CEO of the hospital. Here's some peer-to-peer review tips to share with physicians engaging in the activity. They should always start the conversation by introducing themselves by name and their clinical background and role in the patient's care. It's then important to ask the managed care medical director about their name, clinical background, and role. This is when you'll find out if there's a knowledge gap about what skilled nursing units do and their outcomes. You may ask, have you ever provided care in a skilled nursing facility? This is an excellent time for the physician reviewer to provide education. It's important that the physician tell them that they document every intervention, including phone calls, in the medical chart. The physician should emphasize the need for ongoing management of not only medical but therapy needs. Explain why that care cannot be provided in the current care site or a lower level of care. Explain the risks of not having that skilled care. If the peer-to-peer health plan physician does not approve the admission, at this point the physician may file an appeal on behalf of the patient, and it's good to advise the health plan physician that they are going to do so. Remind the managed care medical director that the physician has documented the conversation in the chart with the reviewer's name and role at the health plan. Let's talk a little bit more about Medicare Advantage Plan Joint Quality Operating Committees. The goal of such a committee would be to develop proactive collaboration meetings to improve care and outcomes of their members and create administrative efficiencies for both organizations. The frequency of these should be typically quarterly. Committee members that are recommended would be that referral hospital or maybe a joint venture partner administration. We would want to include our medical director, executive director, CEO, and clinical liaisons. The health plan, director of utilization or case management over the post-acute care component, and the pertinent medical director reviewers are all very appropriate committee members. I typically create a draft agenda and send with an invitation to the meeting. Here's a sample agenda. Introductions. Discuss referral rates. How many of these cases are being referred to us by the hospital? How many do we think are appropriate for skilled? In other words, how many do we internally deny? And then how many are we sending to the health plan for approval? What's our overall Medicare Advantage referral approval rate? That way they can gauge whether they are more obstructive or more on par with other health plans in their area. We do want to be prepared to talk about their patients that we've cared for and their metrics and outcomes. For example, what's the patient's case mix index, their admission functional improvement measure, the gain that they made, their discharge disposition, and if they did go to the acute care hospital, what do we know about this case? Why did the patient go back? Again, be prepared to discuss individual cases in addition to review statistics. We also then on this agenda want to talk about what is their plans, or it may be an ACO and not an Advantage plan, and what is our experience with the review process. This is when the plan might tell us that they view our clinical liaisons as being too aggressive and wanting to admit patients to skilled that really are more appropriate for home care. Then the goal of the meeting, of course, is to develop a process to ensure that the Medicare beneficiaries have access to appropriate benefits, yet making sure that we keep care quality at the center and create efficiencies for our organizations to work together. This following slide talks about language that we might use in our documentation or language we might use in a peer-to-peer and why that is a red flag for the health plan. Then I've given you some green light language about better language to use to get success. So for example, we may say the patient lives alone. The health plan medical director may think, well, that seems like a social issue. It's not what we cover in benefits. But what we really meant to say was that the patient was independent at home prior to this event, and there's an expectation of returning to the prior level of function to maintain independence, thus avoiding a readmission. I'll let you review the rest of these. Let's do a little case study about how using this language can be helpful. We have an 84-year-old man with a history of congestive heart failure, type 2 diabetes, and has been in the acute care hospital for 3 days following an acute exacerbation of congestive heart failure. He also had an hypoglycemic event. Before the hospitalization, this patient lives with his spouse who provides minimal assistance with lower body dressing and bathing. However, she's of petite stature, and thus the patient needs to regain pre-hospital function to return to his home. Note that the home has stairs to the bedroom and bathroom. Here was our recommendation by our clinical liaison. The patient needs 24-hour nursing care, 120 minutes of therapy a day, focusing on OT, PT, and speech to return home with the prior level of function. We're going to involve social services for that discharge planning and get a psychiatry consult because the patient's exhibiting signs of depression. We're going to offer frequent physician visits to manage all of the acute and chronic care medical needs, and we reasonably expect that the patient will be able to actively participate in therapies from the time of admission for an expected length of stay of 14 to 21 days. Did the health plan approve? No, they didn't. Their rationale is that the patient can continue their care at the hospital until the pulmonary status, type 2 diabetes, is stable and then go straight home to home care with therapy. Their question is whether the patient that has undergone this sort of acute exacerbation can really withstand 120 minutes of therapy a day. And in their view, home care can provide PT and OT and monitor the diabetes. How do we get to yes, and how are we successful in these peer-to-peer discussions? Keep in mind, the admission coordinator is directly reviewing the case details. This could be a clinical liaison, and they are discussing it with bedside clinicians. However, the health plan utilization management nurse and medical director are reviewing notes, scanned into the computer file, and comparing to Milliman version 17. Our advantage is that we are a skilled facility and we understand what can be provided and how the patient is meeting the criteria. We are most familiar with the criteria and recall that many nurses and medical directors of the health plan have never set foot in a skilled facility. However, we're driven by patient-centered care, attaining the highest quality outcomes to attain maximum function in the least restrictive environment, but it's important to know that health plan clinicians are often incented by reducing inpatient admissions of any type. So let's re-examine our skilled facility recommendations. How would we turn that language to green language and get to yes? When we say 24-hour nursing care, we need to point out that our nursing oversight is much greater than can be delivered in a home care model. We talk about 120 minutes of therapy a day. We can talk about home care providing therapies, but certainly it's intermittent and not at that level of frequency or duration. Note, we probably set off a red light when we talked about returning to their prior level of function of independent ambulation. We stated earlier in our review that the patient requires minimum assist of lower dressing and bathing, so that the wife will need to be educated to better assist with these functions. So saying that the patient's going to go home totally independently is an unrealistic expectation, and we need to make sure that we align prior function with our expected goal. Social services for discharge planning. In many of our skilled facilities, our therapists will do an in-home assessment prior to discharge. And the psychiatry consult, it's basically, we want to point out that it's to manage anxiety and depression related to shortness of breath, not that the patient has a behavioral health disturbance, for example. Daily physician visits to manage cardiopulmonary needs. It's more effective if we more thoroughly describe that, such as ongoing oxygen monitoring that may occur with increased ambulation. And patient reasonably expected to actively participate. Note, the health plan has targeted skilled nursing facility length of stay goals, and you may have a concurrent review process that happens more frequently than at the beginning and the end of the stay. At this point, you could invite their concurrent review case manager to call into your case conferences so they hear firsthand what the patient's remaining needs are. Thank you for participating in this session on the crucial topic of managed care success. We want to keep the Medicare beneficiary at the center of care and make sure they are receiving the benefits they so richly deserve. Thank you and have a great day.